So today's topic is food allergy and Dupilumab. And my name is Will Collins. I am one of the docs here at the Sean and Parker Center, and I also work as a clinical assistant professor at Stanford. We'll be talking a little bit about, I think I already said that, but anyways, let's get started. So just some disclosures. One of the trials we're talking about, I'm the principal investigator here at Stanford, and we do get the Dupilumab product from Regeneron for that study. So I wanted to make sure I disclose that as we begin. So just an introduction to this talk. We'll talk a little bit about food allergy, an overview. Many folks know a lot about food allergy in this audience, but just review a little bit of our successes and some of the work to be done. And then that can lead into talking about how Dupilumab works, how it might work in food allergy, and some of the studies here that we're currently enrolling and will be enrolling in the near future. And then we should have some times for Q&A. So I thought this was a cool chart, so I wanted to bring it to everybody here. Shared by Dr. Nadeau to our team. This is showing population-based estimates of food allergy in children across the world. You can see that areas with the highest prevalence include China, some in Northern Europe, and of course the US and Canada. And in the US, the estimation of the rate, although the writing here is pretty small, is 7.6%. So if you take a pediatric population of about 73 million, that's about 5.5 million children dealing with food allergy at this time, which is certainly no small number. So what have we been successful at in food allergy? Well, many folks here know about oral immunotherapy, basically challenging participants or patients with the food that they're allergic to at increasing doses. The goal of this is to, one, induce desensitization, i.e., allow them to tolerate higher and higher amounts of the food that they're allergic to, also increase the threshold at which they might have a reaction. So if they had an accidental exposure, it's less risk because it would have to be a higher dose to cause a potential reaction. And then this therapy, once you achieve desensitization, it can be maintained with daily dosing of the allergic food. And now we have FDA-approved therapies for it, that being Palforzia for peanut allergy. So what is our work to do? Well, we know that OIT does pretty well in terms of inducing desensitization, i.e. Allowing people to eat more of the food they're allergic to. But one thing that we'd love to see increase is the rates of sustained unresponsiveness. So that's when someone does not have to continue dosing frequently with that food product to maintain their desensitization, but can in fact go off dosing and they continue to maintain that unresponsiveness. And another thing that we have work to do on is trying to reduce symptoms that limit oral immunotherapy. In particular, participants are often limited by GI symptoms when trying to do OIT. And so ways that we can augment the therapy to help reduce those symptoms would really help in expanding people who can take the therapy. So that leads us to Dupilumab. So Dupilumab is a monoclonal antibody and it works. This is a busy figure, but basically what Dupilumab does is it blocks one of the chains of a receptor on immune cells. That receptor chain is the IL-4R alpha chain, for those taking notes. But basically what this means is that when you block that receptor chain, you block the binding of two cytokines in the body that are important for allergy signaling or converting to an allergic response, those being IL-4 and IL-13. So basically, this is an antibody targeted at the cascade that occurs in people's body that leads to the Th2 or allergic response. So Dupilumab is currently approved for several conditions. Those include moderate to severe atopic dermatitis. It's also approved for persistent uncontrolled asthma, particularly allergic type asthma or eosinophilic asthma. It's also approved in chronic rhinosinusitis with nasal polyposis. And then there's ongoing investigations to see if it can be helpful in EOE or eosinophilic esophagitis, and of course, food allergy, which we'll continue to talk about here. So any medication has side effects. I did want to make sure that we talked briefly about that. So in the trials for which Dupilumab was approved for other indications, there were some more commonly reported side effects. It is an injection, so injection site reactions were reported. Excuse me. There have been reports of dry, itchy, red eyes occurring with treatment, particularly in the studies of atopic dermatitis or eczema. Antibodies can also develop Dupilumab, but often they don't actually block the action of the medication. And I'm going to pull down my mask because I fear I'm hard to understand. And then you can also actually get antibodies that develop that can block the action of the medication, but that's less common. Some other less common things there, including cold sores, different types of inflammation of the eye or eyelid. And then there's rare side effects of hypersensitivity or serum sickness, which is a hypersensitivity reaction characterized by like fevers and joint pains, and very rarely blood clots have been reported. That said, we look for the positive, the benefit over risk when trying to see if medications are good for things. And so for Dupilumab and food allergy, the potential is that by blocking this allergic response, giving it during OIT, you could improve rates of desensitization, decrease rates of adverse side effects, particularly those GI side effects, and increase the rate of sustained unresponsiveness, which is really the gold standard that we're trying to achieve to get people to a point where they just wouldn't really have to worry about that food allergy anymore. So as far as studies that are currently enrolling here, one study that is currently enrolling is the combined study. This actually uses both Dupilumab and Omalizumab. And so it's a multi-allergen OIT study, that being peanut plus 1 or 2 additional foods. The study basically starts with Omalizumab or placebo and then goes to Dupilumab or placebo. I'll show that on the next slide. The reason for including Omalizumab, I'll just touch on here briefly, is that is actually a antibody towards blocking IgE from binding. So it's also blocking another pathway by which the allergic response could develop, potentially lowering the levels of food allergen-specific IgE. So as far as those who are eligible for this study, those ages 5 to 55 who have peanut allergy plus 1 or 2 of these additional foods: milk, almond, shellfish, fish, cashew, hazelnut, egg, walnut, sesame, soy, or wheat. So again, this is a currently enrolling study here at the center. And then this is a schematic for the study, just so people are aware of roughly the time for it and what happens. Basically, persons are randomized to either an initial therapy with Omalizumab, followed by OIT with either Dupilumab or placebo, or placebo followed by Dupilumab with OIT. So the nice thing about this study is that you get one or both treatments, no matter which arm you're in, you will at least get one of the treatments. And then the MAGIC study, I think there was a question. It's not enrolling yet. We hope to enroll soon, maybe later in the spring or early summer. This is a study looking at cow milk OIT with Dupilumab, and it is enrolling folks between the ages of 4 and 50 with cow milk allergy. And so a little bit shorter study, but basically there's an initial treatment with Dupilumab alone for 4 weeks. Then participants start OIT with either Dupilumab or placebo. And then there's a phase called the washout phase, which is basically a continuation of OIT without the Dupilumab or placebo. And then there's several food challenges there to see how well the therapy works. So that was pretty brief, but here is a nice puzzle piece that we like to show that looks at our current and near future enrolling studies. So we talked about MAGIC and combined during this talk, but also some other very interesting studies One to highlight is Sunbeam. That's a study in pregnant women and their babies, basically looking at how food allergies might develop in young childhood. So I think a really interesting study as well. And wanted to make sure we highlight all our team and our great support. And I think we've got several questions, so maybe we'll take some time for those.
Thank you so much, Dr. Collins. If you don't mind just putting up the contact us slide, and then we'll swift through some questions we have here. Thank you so much. So one of the questions, our son does not enjoy having to eat his 6 different nuts every day. He's been doing this for many years. Is there any update on our understanding of how long people need to take maintenance doses, or how frequently each week they do?
So that's a great question. I don't know if there's any more specific trials that have looked at that. As we talked about, we certainly can see that OIT helps with desensitization, but as far as maintaining that desensitization, it does seem that if people go off of the maintenance therapy and then they can redevelop sensitivity to those allergies. I'm not aware of any studies ongoing right now to try to understand that better. I don't know if anybody else in the panel has any other thoughts on that.
All right. I'm not sure if Tina, Kathleen, Katie wanted to chime in.
Welcome to if they can. Otherwise, we
move
can
on to the next.
Move on.
Yeah, and I'm on. Tina's on. I'm happy to. Would you mind? I was just on a different item here. Would you mind repeating the question?
Oh, Tina, basically,
Sorry.
it's a kid who is on 6 different nuts, having to do ongoing maintenance dosing, and just wondering if there's any updates on spacing out maintenance dose, or how long people need to take them.
Oh, like the duration or the
Yeah.
frequency? So as of right now, I know prior studies have shown that if someone is doing maintenance dosing to much higher amounts, like 2,000 grams or 6,000 milligrams, then they can space them out to every 3 times a week. But if it's a low dose maintenance, like 300 milligrams, it has to be daily. And in terms of duration, as of right now, we think it's indefinite. We are looking at a lot of long-term follow-up data and studies, and trying to understand, is there an ideal number? Like if someone's been on OIT for, let's say, 10 years and have not had an issue, can we then say they've, quote unquote, been cured or have outgrown their allergy at that point? And we are not there yet. So as of right now, we're saying indefinite maintenance dosing until we find some new data from our long-term follow-up studies.
Thank you, Dr. Cinder. So the next question we have is, do you know if combining OIT and Dupilumab reduces the incidence of EOE during OIT?
We don't know that. That's some of what we're studying, actually, is to see if Dupilumab can help with that. So that's part of the reason we're doing these studies.
The next question we have here is, what are examples of steps being taken to reduce GI symptoms?
I think some of the examples here are trying to explore different therapies that we could use in combination with OIT, including Dupilumab, omalizumab. There's some other potential therapies that may be helpful that we'll likely explore with trials in the future. And then, of course, we always, when we have participants, we work with them in terms of using some more common medications, histamine blockers, acid blockers, things like that, which can help with symptoms.
So the next one I have is, will this or similar types of therapies be developed for tree nut allergies without peanut allergy?
So, well, so the combined study does potentially have folks enrolled who would be doing the therapy that would include tree nut allergies. The question, are there studies where, I guess if the question is there a study with just tree nuts and not peanut as an inclusion criteria? We don't have any studies like that right now, perhaps in the future.
The next question here we have is, do any of the Dupilumab studies for the food allergy desensitization allow for patients with existing EOE?
Generally not. The trials having had EOE as an exclusion.
The next one we have here is, what have you found so far to the difference between Xolair and Dupilumab as far as impact on OIT or EOE?
So I think at this point, I don't know that we have enough data to say one way or the other. There was a prior study looking at Xolair with OIT, which did show some benefit. And that's why we're expanding using that as well as using some of these other therapies.
The next one says, any explanation as to why only certain countries have high pediatric food allergies?
Oh man, I think that's a whole nother talk. And actually, I think Dr. Gia spoke a little bit about food allergy around the world at one of the prior talks here. It's a hard question to answer. Some of it may just be the ability to diagnose and report food allergy better in certain countries versus others. Some of it may be environmental. It's probably a longer answer than that, but.
Thank you. How did you determine to only treat with Dupilumab for only a 4-week period prior to the OIT phase beginning versus treating with the medication for a longer period of time before starting the OIT phase?
So the protocol was designed this way with the hope that a shorter time lead-in with Dupilumab would be helpful. So that's the way that we're initially testing it. I suppose it is possible that treating with a longer run-in could potentially provide more benefit, and perhaps that's the next thing to study after we look and see if the 4-week period is helpful.
Is there a reason why the combined study is limited to those older than 5? Why not younger kids?
That's an interesting question. I'm not sure I can 100% answer that. I think it was just in thinking how to design the study and who to enroll and who could interact with the study. Also, it may have something to do with having multiple allergies. Often you see that in kids a little bit older.
Thank you for that. What opportunities are there for adults who don't have peanut allergy, but other food allergies and eczema?
As far as at our center, I presume that's asking. If you don't have peanut allergy, we spoke a little bit about the MAGIC study, which will look at cow milk allergy. And then we did have a study motif that was looking at shrimp as well as cashew allergy, although I think that's mostly wrapping up at this point. But certainly, if you join our registry, we can definitely keep your information. We would know what food allergies you have, what other allergic conditions you have, and always be on the lookout if we have new studies that would be potentially something that you'd be interested in.
If a patient has a very high IgE, would you suggest they try to enroll in a trial that uses Xolair versus Dupilumab or both, versus a trial that is only giving Dupilumab?
That's a little hard to answer. Depending on the IgE level, it might be something that you couldn't necessarily enroll in a study with Xolair. I don't know that I could speak more beyond that. it'd be sort of hard to answer. I think that's probably something you'd want to know a little bit more about that person and understand what's going on with the high IgE, and then think about what potential studies they would be a candidate for.
All right, we have our last question here. Do you use Xolair or Dupilumab out of the clinical trial settings for OIT?
I personally don't practice allergy outside of the clinical trial setting. Some other folks on the panel do. I'm not sure if anyone is using it at this point. Certainly they're used for other conditions, including asthma, which I know a number of people have used both for. But I'm not sure if there's anyone else on the team who's had experience outside of the clinical trial setting.
Yeah, and I can speak to this a little bit. And this is Tina Cinder. So one of our the part of the reasons the trials are so important is not just to look at safety, not just to look at efficacy, but after those are established, to get FDA approval. And once we have FDA approval, we can actually have insurance companies cover it. Without FDA approval, one of the biggest drawbacks to using this in the outpatient clinic outside of clinical trials is the cost of these biologics. And they go, I mean, upwards of thousands and thousands of dollars per vial. And we're talking every 2-week monthly doses for many months at a time. So we are that some private practices are able to utilize, I think, Xolair. But I think there's an out-of-pocket cost to this. But once FDA is approved, we're hoping to be able to use it for more patients. So that's keeping our fingers crossed there.
I think that's the time that we have for our webinar. Thank you so much, Dr. Cinder and Collins, for answering questions, and Dr. Gia as well. I see you answered one through text. So thank you everyone for joining us once again for the Ask the Expert. We have the next one for February 23rd, I believe, with Dr. Katie Fast. And so we also post our recordings on our YouTube page. I sent that through the chat. If you have any questions,